Next, we have Dr. Devendra Maheshwari. Sir will be talking on one of the greatest conundrums, whether we should go for laser iridotomy or lens extraction. What is the current trend in PACD management? Over to you, sir.
Yes. So good morning, everyone. Thank you, Scientific Committee, for giving this opportunity, and thank you, Madhvi, to inviting me in your IC course. So today I'm talking about the laser peripheral iridotomy and lens extraction in primary angle closure disease. So it is a controversial topic. Some people used to perform still like to do the LPI instead, and the recent trend is coming. People are doing the cataract extraction instead of the LPI. So somehow there's a little bit controversial topic. It depend upon the what you want, and we have just searched for the few literature. So what the literature suggested and what should be the current practice. Why it is important? Because we see the incidence of primary angle closure disease is going to be huge. If you see that by 2040 we will have the 21 million PACS case, and followed by the 4 million PAC, and 2.4 million will be the PACG. So we have the large chunk of the population of PACS in the future. So either what we are going to do in such cases, either we are going to observe or going to the LPI. So these are the various multifactorial disease, primary angle closure, having some genetic, anatomical, and some environmental factors play a role to developing the glaucoma. These are the various mechanisms of angle closure, including plateau iris, pupillary block, phacomarpic, aqueous misdirection, and the mixed mechanism of the glaucoma. So we know how the disease progress, really how primary angle closure, natural course of the primary angle closure really is, we don't know. But actually the study done by the Thomas et al. Has showed the PACS convert to the 22% PACs convert to PAC at the end of 5 years, and out of nearly 30% PAC convert to the PACG. So these are the various treatment options available for at present for the primary angle closure disease, as discussed by my previous speaker. So I will just talk about that LPI and the cataract extraction. So as all we know that by doing the LPI, why we are only dealing with the only single mechanism. What we are doing, the pupillary block. Pupillary block is the most common mechanism of IOP elevation in PAC and PACG. By doing the YAC-PI, just we are relieving the pupillary block, widen the angles, and reduce the pressure difference between the posterior chamber and anterior chamber. But even after doing the YAC-PI, certain angles don't open and IP didn't come out because the part of the angle closure is not due to the pupillary block. There is certain other mechanism involved, like the much more narrow angles, more anterior iris insertion, thicker iris, plateau iris, and the large lens. So by doing the YAC-PI, we are dealing with the one part of pathology of the angle closure. So we have to think, why are we doing the more LPI? Is justified or not? And how we should manage the asymptomatic PACS. So these are the various studies has been done. They said, they concluded the primary angle closure suspect, only the few cases we reached to the acute endpoint or develop the acute angle closure glaucoma. So these are the studies, I think, well covered by Dr. Indra. Singapore asymptomatic narrow angles iridotomy analysis study. In this study, they did in the patient, they recruited the 476 patient, one eye underwent iridotomy, second eye for the observation, and the endpoint was either elevation of the IOP or developing the acute attack. And what we learned, without intervention, 10% of the PACS progressed to the angle closure versus the 5.3% in the LPI group. So even after doing the LPI, certain patients developed to the angle closure glaucoma. So that another trial is called the JEP trial. This is also compare its outcome, compare the intervention LPI in the one group, either the observation in the other eye, and what we find out, the rate of developing any angle closure without watch much lower, expected the primary angle suspect less than 1% of the year. So what we learned, even after doing the YAC-PI, we are not preventing the angle closure glaucoma in all the cases. So therefore, despite the YAC-PI is not recommended to the general population or into all the PACS patient. But we have to keep in mind, JEP trial has some issue. Most of the patients are Chinese and the younger population are recruited from the community. So there the argument in favor of the LPI, why we should do YACPI, because acute angular closure is a potential blinding disease and no harm in doing the LPI, because LPI is a non-invasive procedure, can be performed in the OP settings. So argument against the LPI, because LPI is not totally blind, you may have IOP spike, iritis, and can accelerate the cataract progression. So what we should do? So World Glaucoma Association do the consensus for the PACS, which PACS should go for the LPI. The patient who having the fellow eye, having the PAC or primary angle closure or acute cataract, symptomatic PACS, patient who need the regular dilatation, like having some retinal pathology or poor access to the healthcare system. They coming from the rural part, coming to one time, coming to the hospital, they are not coming to you again. I think this is a nice, good opportunity to go for the LPI in such cases, and the family history of the angle closure disease. And recently we saw in the, either we remove the cataract, either clear or cataractless lens, we removed it, definitely IP is going to come down and improve the outflow facilities. So the various studies has done and showed it after doing the cataract surgery, in compared to the traditional treatment like trabeculectomy or LPI, IP is going to come down and almost equal to the other interventions. So this largest trial has been, worldwide trial has been done, is called the Eagle trial, in which they compare the phacoemulsification IOL implantation versus LPI in the PAC and the PACG cases. So what this trial recommended, the clear lens extraction was superior than standard care in terms of the patient-reported healthcare, IOP control, and need of the anti-glaucoma medication. But these results indicate clear lens extraction should be considered the initial treatment for PAC and PACG with increased IOP. However, we should keep in mind when we doing the clear lens extraction, it's a trend toward the clear lens extraction, but keep in mind, discuss with the patient all the options, because still in India, we feel there's no need to trend for the clear lens extraction. And they have some issues, like they have the not true lenses. The most cases are mild cases, and Eagle trial mostly dealt by the experienced surgeons. Coming to the argument in favor of the lens extraction is provide good IP control, cost effective, improve the patient's quality of life, better safety profile, and need the less anti-glaucoma medication. But why we should not go for the lens extraction, especially in developing country or country like India, because the complication of the surgery and the intraoperative complication surgery, especially in India, when we don't have the enough manpower of the qualified surgeon, even if the experienced surgeon can have the complications, especially in the PACG and angle closure disease. And in developing countries, definitely we have the cost is the major concern. We can easily do the YACPI instead of going for the clear lens extraction case and the risk of infection. So just to summarize, medical management LPI remains the most common mode of the treatment. The decision to be clear lens extraction must be individualized, weighing the risk and benefit and complication of the intraocular surgery. So we should understand the PACG, primary angle closure disease, is not a single disease, is a multifactorial and is a multiple stages of the disease. So each patient can be unique in terms of disease stage, and the management should be tailored according to the stage of the disease. Thank you, Professor.